Hello, everybody. Super glad you guys could make it on a Thursday, misty 8:30 in the morning. I hope all of you are excited. We are very excited. I think for those of you who have been in this space or are doing work in the healthcare, I hope you'll find this and where we are going pretty exciting. What I'm going to do is I'm going to breeze through my section, which is sort of what and how this came about. And then I'm going to hand it off to the most exciting piece, which will be a demo. And I'm trying to save a lot of time for Q&A. Right? So please bring your questions. This is really for you. So any kinds of questions is fair game. So with that, I'll just get started. I'm Naveen. I'm a general manager in the health and life sciences at Microsoft. I'm focused on two initiatives: building healthcare AI models, mainly multimodal AI models, medical imaging, diagnostics, those kinds of imaging models, and the second one is agentic workflows, right? So just a quick sort of thing, just to give you like how we think about the health and life sciences at Microsoft. So we acquired a company called Nuance, and for the first time in Microsoft's history, there's a division of 3,000 people of data scientists, product managers, and engineers, all focused on delivering a health and life sciences workloads. And I think, if you know anything about Microsoft, Microsoft loves its stacks, right? So at the bottom of the layer, you've got Azure, and this is things like Epic on Azure, all the source systems, that's infrastructure. You go up a layer, it's these data platforms, Microsoft Fabric, and so we have healthcare data solutions in Fabric that does transformations and normalizations to data models like OMOP and relational fire. If you go up another layer, we have the Microsoft Foundry. Microsoft Foundry is where you'll find models and agents and fine-tuning and running experiments and leaderboards and all the things you need to be able to fine-tune or distill or optimize your models. And you go up a layer, you've got Copilot Studio, which is sort of our low-code, no-code. So we have an offering there called the Healthcare Agent Service. And that is something that can get you going really quickly. HIPAA, it's got all the regulatory compliance. And then if you go up a level, you've got the Microsoft Copilot. And when we say Microsoft Copilot, we really mean a family of Copilots, one of which is the Dragon Copilot. How many here know about the Dragon Copilot? All right. Dragon Copilot is sort of the ambient scribe that's deeply connected into EHRs, and we have a Dragon Copilot for physicians. We recently announced a Dragon Copilot for nursing, and we are working on a Dragon Copilot for radiologists. All right, so now I'm going to jump into 2 or 3 pieces of work that we are doing that we are very excited about. The first is in the Microsoft Foundry, we have a bunch of models that we have built, and I'll talk about those. We have a bunch of models from NVIDIA, from some of our key partners. We have models from other third parties that we worked in collaboration with around pathology, and we are adding more depending on demand and the use cases. Now, the 3 models that we have is currently state of art. We've been able to keep up. There's a big difference from the other models we are seeing. The first one is called Medimage Insight. Medimage Insight is primarily an embeddings model, right? So it's got an embedding space. It works on multiple modalities that you can see behind, CT, MRI, and X-rays, and so on. And the idea with the embedding space is that you can adapt it to multiple tasks with limited amount of training. Right? So it's a task-adapted embedding space, gives you a lot of sort of sense about what is the nearest sort of features that can correlate with each others to ask you questions. So from that, you can do a variety of different tasks. Then we have Medimage Parse that sort of takes that embedding model and adds a task adapter. Now, from this, you can do things like segmentation. You can ask it questions, and you can use it for both all the modalities we just talked about, but we have also added 3D into that. And then finally, you take that, and then you add the textual component along with it, an LLM reasoner, and that's our CXR report gen. That's for report generation for chest X-rays. So we are announcing today a set of premium models. And really the difference between what is available on the, sort of think of them as the open source MIT license versus the premium models is that we have sort of spent more time and acquired more data sets and worked on very, very specific sort of performance gains to differentiate ourselves, right? And it gives you very good ideas. Now, each of the models that I talked about in the Model Foundry have model cards that have all the benchmarks, have all the data sets that it was required, that it was trained on. This adds on more data sets to that. And we have seen, at least on the MedImage inside the embedding model, about 7 to 15% of performance gains for a variety of tasks. And now we are taking the same thing. We're working with a few collaborations, and the one that I'm really excited about to talk about on the agentic side is one such collaboration we're doing. And we have taken that and built a CXR report gen, which also is starting to see a lot of performance. Now, one of the challenges every time we go and try to do one of these things is about model evaluation, right? And really the thing is that if you go to Microsoft Foundry today, you will find ways to do evaluation, but they don't speak health language. They don't understand clinical tasks. So we just released the Health Model Evaluator. It's an open source library, right, meant primarily for research, right? It is not meant to be a device, but it allows you to do things like LLM as a judge, human AI experts, annotation, create these experiments, attach it to certain clinical tasks, and sort of do this. And you can hopefully add it to your RL feedback sort of things to continuously improve your things. So this is available in GitHub. If you look at Healthcare AI Model Evaluator, you should find it. Now to the most exciting part, which we are really, really excited. So last year, when we started on this project, we were still trying to convince ourselves and customers that agentic orchestration was a really, really big deal, right? And we went searching for a use case that could demonstrate that, right? And that is where we partnered with Oxford, NHS, and really sort of brought this to life. Now, in this particular, again, this is available through GitHub, right? And I'll talk a little later after the demo about where we are going from here. But essentially, in this agent, you're able to orchestrate across a variety of different agents to construct something like to orchestrate something like a multidisciplinary tumor board, which makes people more effective and productive, right? So you've got an agent for patient timelines, you've got an agent for patient summary, you've got an agent for radiology images, you've got an agent for pathology slides, you've got an agent for clinical guidelines like NCCN for cancer staging, and you've got agents that look at literature like PubMed and others. And you can add your own agents, right? We are partnering with a few companies that are building like real-world evidence agents like Atropo, that can add into this sort of framework. Now, the most important thing that when we started thinking about this started from really 3 shifts that we're seeing in the industry. And at some point, I'd love to sort of check on that and see what you guys think. One is that these app boundaries are fusing. What I mean by that is now more and more we expect to do the work in the best tool available to us. So I could start on Epic, right? And I could do, say, a surgery prep that's triggered through Epic. But I want to collaborate with others. And so the pane of glass in that collaboration can be Teams. So I expect to take my memory, I expect to take my context, what I'm doing, who I am, into Teams, and there should be a seamless use. So that's the first shift that I see happening. And if we get this story right, there won't be cliffs in the way we do it. And that was one of the experiments in this example that we'll showcase. Second is obviously the way that we organize our personal life, right? We have all got a OneDrive for our personal life, photos, PDFs, all organized for us, and we can search through that. Now you're having a OneDrive for your enterprise life, right? All that data silos are are coming together with one single semantic model to support them, right? So now you can truly build a reasoning layer over all your data, right? So that's the second shift that's happening. And the third shift, which I think is the most significant, is, and this is where Microsoft talks about being a frontier firm, is how do you then reimagine these workflows, right? Now you can start thinking about workflows in an entirely different way. And I think the companies, in my view, that can reimagine the workflows will be the difference makers in this new agentic AI world. And so when we approach this, we started from the best pane of glass to do work. So in this example that you'll see, and I'm really, really excited to introduce Dr. Andrew Sultan. He is a MD, PhD from Oxford. He is practicing in the Oxford University Hospitals. He is also a research fellow for the engineering at Oxford. Now, what is most exciting about Andrew that we have had a chance to work with is that he took an idea that we had and really made it real. And he was telling me a little bit of a story the other day that one of my colleagues were visiting him, and he was in VS Code trying to fix an issue where the LLMs were not calling the functions. And I was like, aren't you an oncologist? But he said he loves writing code. He's been writing code forever. With that, I'd love to introduce Dr. Andrew Sultan.
Thank you, Naveen. I'm very excited to be here. Now, what I'd like to do is share a little bit about the work that we've been doing in Oxford for the last couple of years. And we've been very fortunate to have been supported on this journey, initially by a grant from Microsoft Research and Accelerating Foundation Models Award, and then later through the partnership that we'll discuss today. Now, to tell you a little bit about our institution, the University of Oxford is, of course, based in the wonderful city of Oxford in the UK, beautiful historical buildings. And it is made up of departments and also made up of the hospital trust. And there's a strong partnership that exists between the university and between the trust. That partnership is what allows the researchers of Oxford to develop technologies in the lab and then to begin to see them through into clinical practice. Now, with health AI, the most important thing is you have to do it right. It's got to be governed properly. It's got to be built properly. You need to think carefully through your design choices and the modeling, and also through how you do your implementation. Now, our hospital provides regional cancer services for up to 2.3 million. That depends on the cancer types. So for the rarer cancers, it'll cover the larger population. And for the more common cancers, we have a smaller catchment area. And the hospital is also a major regional employer with 16,000 staff across the organization. And the university and the hospital are in close tandem. They are in places only a minute or two's walk apart. And the challenge that we set out to solve in 2023 when we first applied for the Microsoft Research Accelerating Foundation Models Award is around how we plan treatments for patients who have a new diagnosis of cancer or who have a relapse of cancer. Now, the current workflow in the UK is that every patient who has a diagnosis has their case reviewed in what's called a multidisciplinary team meeting or a tumour board. And in that meeting, typically, a group of experts will get together. It'll be an attending level expert in each of radiology, pathology, medical oncology, radiation oncology, and often also a physician specialist. And the team will go through all of the data that's been collected, the scan results, the blood test results where relevant, the pathology where that's relevant. And the outcome of that meeting is to make a decision about what treatment that patient would have initially, which specialists should see them next, and also try and take into account patients' wishes. Now, the challenge is that these meetings are very pressured. You've got an extremely highly skilled team present, but you'll typically have them for 1 hour or 2 hours, but there are a large number of patients. And that can mean sometimes under a minute per patient. There was a review by Cancer Research UK, which is a very prominent research funder in the UK, that identified the average discussion time for a patient was under 2 minutes across the 10 NHS hospitals that they worked with. These decisions are hugely consequential for patients. For example, a decision may relate to whether or not a patient has surgery, which has recovery time with it, has implications for outcome, it has implications for their quality of life. And the same with chemotherapy and also with radiotherapy. And we asked the question, can we do something to help these meetings run better? Can we help them run more slickly? Can we make sure the right information is there at the right time? Can we go further than that, and can we try and improve the documentation that sometimes is done imperfectly, so particularly around cancer staging, which often there isn't the time to record it in the meeting, and we have to try and do that later. And lastly, can we do something about treatment planning, where we begin to build the scaffold of what the right treatment plan should be, and allow the meeting to review and to ratify that? And I'm pleased to share that we went on to build Trusted MDT as a multi-agent system. Initially, it started out before the days of agents. It started out as a RAG-based approach, and it's since evolved into a multi-agent system. And this really is just a very high-level, quite clinical overview of the sorts of thinking or decision-making that goes on within it. The idea is that if we can very clearly codify the decision-making process, if we can clearly codify how clinicians think to reach the right plan, then we can develop and architect a system that tries to very closely match that process. And by doing that, by clearly defining your process, we're calling this a glass box approach. It allows you to look inside at each decision point and see what decision has been taken at each decision point. That's great for debugging. It means if you find an error in performance when you go on to evaluate it, and I'll talk about that in a moment, you can unpick that. You can see which component, which point in that process needs further thought or needs further engineering or further solutions. And I'm really pleased that we came to meet Naveen, and we came to meet his team and the Healthcare Agent Orchestrator project, which had a wonderful piece of work with Stanford. And we thought, wouldn't it be great if these agents that we've been building could integrate into teams through this platform? That gives us two advantages. One, it brings natural language interaction to our agents. It means that clinicians can interact through a chat interface directly with our agents, which is fantastic. Secondly, and the one I'm most excited about, is that Teams is actually used quite widely to hold tumor boards and multidisciplinary team meetings. Many institutions already use that as the platform, and so that helps us solve the last mile problem of getting the technology into a format that fits within the workflow. And lastly is the orchestration capability of the Healthcare Agent Orchestrator itself. That ability to decompose a complex task into smaller tasks that can be directed to the appropriate agent. And that's allowed us to build our own complex agents. And so we have, to show you our architecture diagram, we've built these three green boxes at the top. Each of them is a module, and each module is itself made up of an orchestration layer and made up of what we're calling sub-agents. And the sub-agents have tools. For example, they can access PDF documents like the clinical guidelines. They can reason across those using frontier models or using whatever infrastructure we would like to build on top of that to try and take that decomposed task and address each individual point in detail. Now, between all of those, there's a strong data contract. So standard agentic practices now, Pydantic is very widely used, where you define very clearly the input going into each module, and you define clearly the output, and that helps your agents communicate. And the glue that ties that together is the Healthcare Agent Orchestrator. So the Healthcare Agent Orchestrator allows us to put our agents straight into the Teams chat, and this is a little bit about our system deployment architecture, and means that users can integrate, can liaise with our agents. And also, we've since moved on to add in that natural interaction. So users, for example, can say, we don't agree with this. We want you to have this additional information. That goes off to our agents. Our agents will then come back with a plan that's been updated to reflect that. Now, we're very grateful to Naveen's team, who've been supporting us partly with funding and also for Oxford University Innovations, University Challenge Seed Fund. And I'd just like to show a video before telling you about the plans we have to evaluate, because technology like this needs to be evaluated very carefully, very thoughtfully, in the right setting before we can begin to think about using it, because it's important to have trial evidence, it's important for you to think about your regulatory considerations. So I'll show a video first, and then we'll talk a little bit about our evaluation plans going forwards. Over the last 2 years, we've been working on a project to develop a series of tools that help improve how cancer care is delivered in hospitals. A diagnosis of cancer is one of the most gut-wrenching things that a patient can receive. We make our decisions on how to treat cancers in multidisciplinary team meetings.
A key part of that is getting the right patient on the right treatment as quickly as we can The opportunities for AI and other associated research to help us with that are fantastic.
If a patient doesn't go through an MDT, they might not necessarily be considered for the right pathway. The core innovation of our AI is the glass box model. Every single decision within the AI is designed to mimic very closely the real process that clinicians go through. Trusted MDT is made up of 3 agents. The first of those agents summarizes the results of cancer investigations in a way that's digestible. The second of those agents stages the cancer using internationally recognized criteria. The last of the agents, and the one that we've spent the most time engineering, drafts treatment plans for patients that are holistic, personalized, and deeply grounded in guidelines. Each of the 3 trusted MDT agents is itself an orchestration of sub-agents. We've given those sub-agents tools to allow them to follow the decision-making processes that cancer physicians take. That means that each sub-agent can be audited, can be optimized, and can be evaluated. Working with Microsoft on the Orchestrator has been a game changer. We've been able to bring that AI Copilot into Microsoft Teams. That's very exciting because for the first time we're able to bring our technology straight into the workflow that clinicians use today. This is early stage work, and we're committed to building the evidence base that's needed for doctors to have confidence that this is safe to use in the clinic. Trusted MDT is entering its evaluation phase. First, we'll be evaluating the performance of the models on synthetic data using expert clinicians from the UK and the US. Next, we'll be asking NHS clinicians to evaluate the performance of the models on real-world retrospective data. Lastly, we're going to move on to a pilot within simulated multidisciplinary teams meetings. And if we find during our study that improvements are needed, we'll be able to pinpoint which sub-agent needs improving. That allows us to generate the evidence needed to show that these technologies are safe and effective in a way that carries no risk for patients. We're keeping humans in the loop. We think that's very important in making sure that errors are picked up and handled appropriately. All of the output produced by Trusted MDT needs to be approved by a clinician before it can become part of care.
One of the things that we constantly try to do at Microsoft with our technology is make sure that it has real-world impact. But of course, when we're talking about healthcare, we've got to do that safely and responsibly. All of that means that we need to find the right partners to be able to achieve these goals. We've done that with Trusted MDT. What does that mean for patients? It means that their doctors are not burdened by looking through so many notes or so many protocols. They're supported by AI in a safe and responsible way.
A key part of Oxford's success is its adaptability. We recognise that to crack the really big questions that affect cancer, we have to work with the best people in the world, such as Microsoft. And over the centuries, that's something that Oxford's prided itself on doing.
The last thing a clinician wants is another application they have to click through. At Microsoft, we see this as a huge opportunity to be able to bring these technologies across the NHS.
Andrew and his team are leading the way for safe and reliable cancer care.
And so I'm excited to tell you a little bit about our plans to evaluate the system that we've built, because this part is really important for us to have any confidence whatsoever. For us to be able to optimize these approaches, we need to have a good way of evaluating it. I'm pleased to share that working with Naveen's team and an external data labeling company, we're putting together a benchmark set of 300 oncology cases, dual labeled by experts in the UK and the US. That's going to allow us to create an automated evaluation pipeline, which means we can continually refine the approaches, we can evaluate them, and we can make sure that we steer the overall system to give results that match what clinicians want. Next, we have funding to perform a 250 case evaluation using expert oncologists on retrospective real-world data. We've received the ethical approval for that, and we're looking forward to starting that early next year. And lastly, the part that I'm most excited about is we've received ethical approval to perform a pilot deployment of our technology of the Trusted MDT system through the Orchestrator in simulated tumor boards. And it's important that we do it first in that simulated setting. That allows us to collect user feedback, usability data, allows us to collect performance data, and then using that information, we'll refine. We'll go back to the code editor, back to VS Code, and we'll refine this. We'll make it better. We'll be able to unpick which parts of the system didn't work as well as we wanted them to, and engineer in new components, new solutions to get that to perform better. That together will begin to form part of a regulatory pathway that would be needed to get, for example, an FDA approval or a CE approval. And those approvals are essential to gaining the trust of physicians, essential to bringing the medical community with us, and essential to seeing a technology like this scaled across the UK, Europe, and hopefully the US. Beyond trusted MDT, we have great ambitions and we see great opportunity in the potential for agents to really improve cancer workflows. It doesn't stop at the problems of drafting plans. It doesn't stop at the problems of dealing with the informatics nightmare in healthcare. But we see opportunities and new applications. For example, as Naveen mentioned, generating real-world evidence where you need it. But there's also synthesizing evidence that exists in the literature. There's also risk prediction. There are novel biomarkers. The opportunities are endless, and we see this as a huge inflection point in AI for oncology. Now, I want to say a particular thank you to the team who's worked with me on Trusted MDT. This would not be possible without the team. I have a very talented group around me, Dr. Sachin Patel from the University of Oxford and Oxford University Hospitals, Dr. Jay Sharma, who's a trainee radiation oncologist at Oxford University Hospitals, and Edward Phillips, who's a doctoral student in engineering who works with Professor Clifton. And I want to say thank you to our senior advisory colleagues, Professor Mark Middleton at the University of Oxford and Professor David Clifton in the Department of Engineering Science. Over to you, Naveen.
Thank you. Yeah, I'm just blown away. I mean, for someone to take a basic idea and bring it to the stage and then think through what the next steps are is just mind-blowing. So where are we going next? So, you know, and truly because of the success of the work that's coming along, we see this now in a quite bigger way. What we want to be able to do, number one, is break those panes of glass, right? So that you can move from one to the other without losing context, memory, or any of those things. The same thing that we are able to do to Streams, we're going to extend it, turbocharge it. We're going to make it so much easier for how these agents get called, how these agents are utilized within a Teams interface. But we're not going to stop there. We're going to take that and light it up in Word, light it up in SharePoint, light it up in Outlook. So if you're trying to send a denials appeals or a prior auth, or you're trying to just send information, and you need to have the information of the patient context, or maybe other scenarios about the device context, all of that in your fingertips, and be able to compose something and be able to share it. We're going to be able to do that. We'll be going to be able to connect it back. Either it's triggered from an EHR or it's utilized within a Dragon Copilot. You're able to connect those back. And then you can take it to other panes of glass because of standardized protocols like MCP. Now what we see is that we want to move into a direction where starting with collaboration is the key. Like I said, we have a Dragon Copilot for physicians, for radiologists, for nurses, but we want to expand that to the entire healthcare continuum, right? But the way we want to approach that is, if there is a collaborative task, if there is a document generation task, if there is an information sharing task, we want to make sure those core set of agents are absolutely working out of the box. Then you got to start adding the kind of agents that Andrew described today. Then we need to then give that power to you all there, where you can start customizing those workflows. You can pick your own agents, you can pick the agents we have, you can customize the workflow, you can customize it grounded. If you want to build a discharge document directly from your SharePoint or your other location, you should be able to just do it and use it for that particular purpose, right? So with that, thank you again. We'll open it up for questions. We'd love for those questions to come. This is really good feedback for us so that we are working in the right direction. And without having this kind of support from you all, that wouldn't be possible. So with that, I'd like to open it up for questions. Thank you.
Hi, thanks for a fantastic presentation. I'm a radiologist, actually, and was an undergrad at Oxford and did a fellowship at RMH. And this session is basically why I came to Ignite. I mean, I didn't know it was going to happen, but it is. I mean, there's so many questions I was going to ask, but first I'd like to salute, Andrew on his approach to AI in terms of governance, because I don't know if there are any other radiologists in the room, probably not, but a huge problem I find in the UK with the radiology AI, and clearly radiology is a massive target for AI because we're all digital, But in the UK, often a hospital will get involved with AI from a centrally funded one-off grant. And because it's free money in a very resource-strapped context, which is the NHS, nobody looks at it critically. You know, it's free money, it's exciting for NHS radiologists. You know, the trust is not going to say no. And obviously the government's not going to say no because it's all kudos. But Andrew's approach in terms of governance, it's kind of like, you know, it's almost like a randomized controlled trial approach to quality. It's unique in my experience in radiology AI, which is an interest. So I was just wondering in terms of the presentation, I was looking hard to try and figure out how you get data into your agents. I kept looking out for which EHR, because then from Manchester, you know, we have Epic, you know, at a classic bare bones NHS implementation. I think we just about, you know, what amazed me was in the keynote, Seth Hain was talking about, you know, like LLM access to data in Epic comes out of the box. Well, it certainly isn't in Manchester. So Andrew, how do you get data into all your agents?
Yes. Now, I want to take that in two parts. So we'll come back to your question in a moment. I want to say, you know, a huge amount of the ability to do work in this way is down to the UK model of academic medical centres, where you have a university that has a deep partnership with a hospital that's quite literally next door and sometimes even share buildings. And the advantage of that solution is it means that the universities can build technology for the processes that work next door in a hospital. Now, traditionally, when developing AI within the academic center, within an academic setting, the big challenge is integrating into workflows. It's, for example, getting your software or what you've built and what you've validated within the workflow that clinicians will use. And that's why this Teams partnership is so exciting for me, because we really are able to put this in the software that clinicians already use in standard care, of course, subject to approval, subject to us completing the evaluation, subject to an FDA and CE down the line. Now, on the question of data, this at the moment is not a CE-marked medical device. It's not an FDA-approved medical device. And so it would be absolutely not the right thing to do for us to hook this up with FHIR into Cerner or into Epic, because we haven't met that quality bar yet. So in the research and development setting, we're working firstly using synthetic data sets that we've put quite a bit of work into generating. My colleague Dr. Satcham Patel has done some fantastic work in generating a really high fidelity data set that looks, smells, and feels like a real world patient record. Secondly, we're using de-identified shadow copies of patient data under ethical approval. So at the moment, we're not using a FHIR connector into Epic and Cerner. However, that's the future. That's where we're going. And there are many projects that are looking to be that bridge, that are looking to solve that data problem, to put your patient data into a standardized data model that you can then work with. And we look forward to collaborating with those when we get to the right point. And
I just want to say, like, I started my career at Microsoft on data for 22 years back. And I think the last year I've spent a whole bunch of time working with Epic. So one of the things that you will see happening because of the Dragon Copilot is we're going to start storing more of that patient context in the customer's environment, right? And it's going to be accessible for both read and write, right? Now, on the Epic Cogito, if you've listened to the talk, that's built on Fabric. And Fabric has a unique capability for data virtualization. That is, without moving data, you're able to connect that data. We have solutions within our healthcare team. One is called, Healthcare Data Solutions in Fabric that tries to connect those dots. And we have, FHIR services and DICOM services that can read FHIR and DICOM for medical imaging. And that's where we are working with PACS vendors on the DICOM side. We're working with Epic to make sure that when I start or trigger a workflow, I can then move it around. And in my environment, that access to data is not broken, right? But that's the path we are going. That's a great question. Thank you. Yeah.
Yeah. So coming to the DICOM and FHIR, how are you guys leveraging Fabric? Is Fabric playing a crucial role? Because DICOM images, they depend upon, for example, for chest X-rays, it is one-dimensional. For example, if it is a brain thing, it has 24 frames. You slice them, you mix them, right? That's a lot of data, right? So how are you guys bridging the gap between a FHIR resource that says a lab report with a DICOM image?
Yeah, no, that's a great question again. And the very simple answer is that underlying OneLake is basically ADLS Gen 2. It's a blob storage, and you can mount that. So you can, and then if you want cold tiers of data, from a cost perspective. So all of that is mounted onto OneLake and can be accessed directly. So when we save DICOM and that, in the healthcare data solutions, we take the HL7, convert it to FHIR to DICOM, we convert that into a relational FHIR, and then you can use SQL tools or any of those tools to access that data.
So I love this, but I don't know about the UK, but in the US, the biggest problem that I see is that the patient doesn't actually have any of this information. Like, you're just given a treatment from your doctors and says, here you go. You don't actually see the decision, the deliberations. You don't see any other paths. Like, maybe I don't want to take, path A, I want to take path B because it suits better my lifestyle. So where's the patient in all of this?
So this role falls to the physician. It is, for example, the oncologist's role to understand what does the patient want, what matters to them, what are their values. And the oncologist, when they go to the meeting, rather than spending their time, for example, trying to summarize the information or to go through it, we want them to use the time to advocate for the patient, advocate for what they've told them in their consultation matters to them, to understand the options, and it then falls to the oncologist when they next meet with the patient to summarize that deliberation, summarize that discussion, and summarize what the treatment options are. Now, our belief here is twofold. First of all is that by trying to free up some physician time from doing the administrative task of healthcare, we hope that means more time to care, more time to have those discussions. And secondly is by improving the quality of the documentation that comes out of these meetings. Even if a physician was not present at the meeting, they will be better able to capture the nuance and the rationale of the decision and be better able to capture some of the alternative options and express them. So I think that this is a part of the solution, but communication skills, that is a huge part of it, and also having the opportunity to meet with your physician to have that discussion and express your wishes is also a huge part of it. So this is part, but not all of the solution.
Hi. In your description, heard you say that you've done a part of the process, the gating through and building this technology was ethical discernment. I'm curious, what were the top one or two things that you needed to do to build trust with your peers that something wasn't missing in the process of working through this and developing the technology?
So I think there are two important parts to this. I think one is the architecture that we've built is one that tries as best as possible to encourage transparency. It tries to decompose a complex decision into a series of smaller decisions that can be audited, that can be traced, and therefore can be improved. Now, secondly is also about how you choose to design your evaluation study. And so, for example, if we were proposing tomorrow to start using this in real-world care, I would quite rightly expect pushback from my colleagues. I would expect them to be concerned, and that would be their duty and their role to be. But here we've gone for the approach of simulated meetings, where we're holding what will be a tumor board. It will look and smell like a tumor board, but the cases that will be discussed will be previous cases that have been de-identified and not live current cases. And so by designing your study in a way that takes that risk out, you're able to collect your usability data, you're able to collect your performance data, but you can do that in a way that doesn't carry the risk.
Hi, thank you for this great presentation and work. My question is about how can we, or do you think that this architecture and solution can be replicated and reused for other topics and to solve other issues so that we don't have to reinvent the wheel, but take it and apply it?
I want to share the answer to this with Naveen, because I think both of us share a vision here, and also you'll remember from the keynote for Ignite, the revolution that is coming with agentic AI is the ability for one to take a complex problem, a complex task, decompose that through an orchestration layer into a series of subtasks, and have specialist workers with access to the right data and the right tools. That isn't specific to oncology in medicine, and it isn't specific to medicine in the world of work. I think we are quite likely to see a revolution in how work is done. And it's going to be around this idea of decomposing tasks, orchestrating across tasks, and then role-based access to the right data and the right tools. Over to Naveen.
Yeah, no, and I think like the way we're sort of envisioning this, and love your feedback on this, is there's these core set of things that you don't, like, we will take care of, right? Like the SharePoint integration, the Outlook, and all of those core tasks. But as you go up higher, it becomes closer to the domain, right? So discharge coordination or surgery prep, and those kinds of things, that's where we need those workflows to be configurable and customizable, right? And extensible, right? And so what I'm going to learn from this is so much on where those boundaries are. We may not get it right in the first thing, but seeing the work that they have done and extending that work, I think is a game changer. In fact, for me, I'd love to ask you all a question, which is, does this idea start to, like these panes of glass, you know, like you want to collaborate in a tool that makes sense. Does that make sense when you're going to take old workflows like surgery prep and transform it into something new? Are we heading in the right direction? A show of hands would be good. Oh, yeah, absolutely. Absolutely. Yeah. There's a couple more questions.
This has been a great talk. I'm a vascular surgeon at Ohio State. Is there a human in the loop on curating your evidence base? A consequence of AI is there's a lot of garbage evidence that's kind of clogging up the system, and how do you help your agents be connoisseurs of high quality evidence?
Yeah,
well, this is an age-old challenge in managing medical literature. The current practice for gold standard in reaching what is high-quality evidence is the idea of a systematic review, the idea of a meta-analysis. And there have been, my group a team around me, I had two very talented junior doctors who came to work with me, have done some fantastic work, for example, on sifting through the literature to screen abstracts. And what they've done in that piece is actually replicate one edition of the Cochrane Review and show that an ensemble of large language models can achieve performance equal to a screener. And that's just one part of that. There are companies now that are doing this as their main reason for existing. So using these technologies, we do see a world where the performance will be good enough that you can screen the literature to help something like a Cochrane Review to produce gold standard evidence.
And some of the things that we are adding is, and there is literature on our website, is called clinical safeguards. So for coding, for all these basic sort of areas, there will be a connection to provenance, right? And that's the glass box approach, but also looking at the exhaust that's coming out of this and being able to look at that in some way in an automated fashion, and then trying to make sure that it's acting up. And I think that part of the system isn't built out yet, but that's sort of, to make this real, it would require techniques of that nature.
Like, pretty impressive what we're doing, right? But in oncology or hospital systems will have deeper pockets to work on these kind of solutions. The kind of technologies we use, they're not that cheap as well, right? So for example, when it comes to care that is supported by, for example, Medicare, how can we, solution is wonderful, like how much the provider gets from the government, for example. Think about this, there is a care scenario where a group of clinicians will come and make a care decision, right? Best tool I can use, save some time. How would we translate that into companies or private equities look for savings, and how, it might be AI, process improvement, clinician wellness, all that, but how can we translate that? My question is more on, does Microsoft has any guidance as we from technology can share with companies? These solutions are valuable, but there is also cost savings involved. That's my first part of question. The second one is, in the US, we have all of us research, right? Where we have the data, but we as Microsoft customers, when we want to train any model per se, or build a machine learning model, or build an SLM, it is getting tough for us because it is all of us research is being hosted by right, I don't want to name, but when can we get that kind of flexibility in Microsoft platform where we have our own kind of a similar data like for all of us research, where we can leverage to build solutions specific to organizations? Is my second part of the question. Thank you.
Yeah, I think the second part of the question is kind of tougher, but we are working on areas where we will build those connections, right? The first part of the question is the next set of focus that I want to be able to do for the next evolution of this product is when you think about three things that are reimbursable for Medicare or Medicaid: transportation, food and safety, depression, are all these things that go uncoded today, right? Those kinds of things, as you bring in the process, and you've got an agent for transportation, you've got an agent for food and safety, you've got an agent for depression screening, you're going to start catching those and make it reimbursable. But the second one, I think, is a great question. All right, there's one last question. Can we take? Oh, it's time's up. Thank you so much, everybody. I hope you liked it.